So we're going to talk a little bit just to kind of to launch into this a little bit about stigma, because stigma really relates to all things we're going to talk about in the future. And so this is a little bit of a foundational talk that Katie and I are going to do. And we all can participate in improving stigma or actually contributing to stigma in the work that we do with the patient population that we have. And I always say that the most stigmatized group of people who are coming in for help are pregnant women with substance use disorders, especially pregnant women of color with substance use disorders, as well as belonging to any other kind of underserved group or group that tends to be discriminated against in general. And so all of us work with a lot of those folks, and how can we kind of make it easier for them to ask for help? Because one of the things that stigma does, which we'll talk about, is make people not ask for help. So it keeps them away from treatment and other resources that could be helpful. So we'll talk a little bit about stigma, what it is, who's stigmatized, who's responsible, and how it impacts both the clients that we work with as well as us. And then some research, we'll look at, some people like research, some people don't, so we'll breeze through that. And then how we all can kind of contribute to changing what's happening. Certainly in the course of my career, I've seen the stigma around substance use disorders decrease, but we still have a long way to go. And I also see it every day, either in small ways or big ways that the folks that I work with report to me about. So what is it? Just a quick overview. I think, Katie, are you gonna?
I'm going to take I will take this over. Thank you so much. So we will just jump right into talking about what stigma is. So stigma is an attitude, behavior, or condition that is socially discrediting. And stigma can occur at multiple levels. If we think about the public level, this would be public policies or laws that get put in place. We'll actually talk about the history of those in a minute. It can occur at the private level in terms of how we humans are communicating to each other from a stigmatizing place. And at a personal level, in terms of how we can actually shame ourselves into thinking that we deserve to be treated in this discrediting way. Oftentimes, the major influence regarding stigma are really the beliefs about cause and controllability. So what our beliefs are and what we think caused the addiction and what control we think the person has over it. Research has shown that addiction is the most stigmatized condition worldwide, and it's one of the few health conditions out there that some members of the public still consider a moral or criminal issue. Next slide, please. Thank you. So the origins of stigma of addiction probably date much farther back than the 20th century, really, when folks and humans started using substances. We're just going to touch on a few of the public policy notes and laws that have existed in our country that criminalized addiction and have really contributed strongly to stigma. So the Harrison Narcotics Act of 1914 is generally considered to be the beginning of the oppressive war on drugs. So the Tax Act was supposed to be, it was touted as a way to sort of solve the opium problem that was taking place in the Far East. And it was doing that by regulating and taxing opiates and coca products. Unfortunately, what it did was declare that doctors could no longer prescribe opiate-based drugs to persons with a substance use disorder. And the idea was because addiction is not a disease. And so this led to doctors being targeted by police. This led to doctors being imprisoned, and it led their patients to now be viewed as criminals in the eyes of law. And that was an incredible problem. In 1919, the 18th Amendment to the US Constitution then also established the prohibition of alcohol. This was another area where this led to all kinds of criminal acts. It led to smuggling, it led to illicit bars, it led to health complications that came from people making alcohol at home. And so ultimately, prohibition created new categories of crimes related to alcohol. That was eventually repealed in 1933. And so what a few of these time periods show is what was a common viewpoint at that time was that addiction is this moral failing. So people were expected to be able to use these toxins with no issues. And if they couldn't, then that was on the fault of the person. And along that viewpoint, the thinking was that substance use disorder has to be treated separately from all other medical treatments. And we've actually seen that continue to play out throughout the medical system. An example of that would be a medical treatment center that doesn't admit patients who also have addiction needs, like needing medication. So that's still something that we combat today. Thank you for already going to the next slide. That was great. So moving along with how we have criminalized substance use disorders in the US, there was a period of time we were going in a better direction in the 60s and 70s. There were several laws that were passed to really help develop a public health response to addiction and treatment. But then former President Richard Nixon came around and interrupted this momentum when he declared that drugs are public enemy #1. And then with Reagan's war on drugs came the recriminalization of substance use disorder, which we really saw play out with the crack epidemic of the 80s. This led to a significant amount of people being arrested for symptoms that were related to their substance use disorder. And so currently more than half of those in state prisons and 2/3 of people that are awaiting sentencing in jail exhibit problematic substance use, or they already meet the criteria for addiction. And the problem with that is, while those folks are in these prison systems and in jails, they have incredibly limited access to evidence-based treatments at the time that they need it the most. Approximately 137,000 people are in state prisons or jails in the US on any given day for drug possession, and they're often possessing small amounts of illegal drugs. And we absolutely know that these penalties are doled out inequitably. So racial and ethnic minorities, especially Black and Latinx Americans, are significantly more likely to be arrested and receive stronger sentencing for drug-related offenses. Next slide, please.
Yeah, and that's sort of
please.
An example of institutional racism that exists.
Yeah, thank you. So here are some common myths about individuals who use illicit drugs. I will imagine you've either heard them yourself or even believe them yourself. I know I have. So, common stigma-related sentences are things like, well, these are folks that don't want help. Addiction is a choice, not a disease. These people are undeserving of help because they've done it to themselves. They have flawed character or poor morals. What I try to remember when I'm working with people who have stigmatizing views about addiction is that often they have their own story. They have their own struggle. Maybe something has happened in their personal story, in their childhood, in their family story, that may be preventing them from being able to see what we can see as professionals in the field. So I want to try to have just as much empathy and understanding for those folks as I want them to have for our patients and for our clients. We know that working with and loving people that are in active addiction can lead us all to experience compassion fatigue. And when that happens, sometimes we get angry or we get frustrated and we blame the individuals for their behaviors that are connected to their addiction. I know professionals in the public realm. I'm married to one of them, first responders. So I'm married to a paramedic. And when he got in the field, he didn't initially understand that addiction is a chronic relapsing brain disease, and he could feel burnt out at times from that population of patients, just constant cycle of needs. I do also think that sometimes folks in the community don't understand just how hard it is to get into addiction treatment and how hard it is to stay in addiction treatment, because we ask an awful lot of our patients. It's a really big commitment. We know the commitment's worth it because we see what happens when folks get into and stay in recovery, but we ask a lot to ask. And additionally, what we know is these folks, I think not everybody always understands just how the adverse childhood experiences that they have experienced in their lifetime, not just childhood, maltreatment, history of abuse, history of trauma, and how much that contributes to them developing their addiction. Next slide, please.
Which is part of what, the goal of Child Protective Services involvement is to reduce those ACEs, and there's a prevention piece to what we all are trying to do with regard to protecting kids. Katie, I just want to let you know, Josh put in the chat also with regard to kind of the criminal justice system interfacing with individuals with substance use disorders, that mandatory minimums is perhaps contributing to some of the institutional stigma.
Yes.
Substance use disorders.
Yes, thank you for highlighting that, Josh. Appreciate it. Next slide. Thank you. So this population we know comes with a list of unique treatment concerns, and this could really probably expand to the whole population struggling with a mental health disorder. So again, we know these folks have a much higher rate of trauma than the regular population. They experience higher levels of shame and guilt on a daily basis. They don't even need that from us. They're shaming and guilting themselves enough. They have a strong fear of CPS intervention and what that could potentially do to their sort of current family unit. And I think overall, just a general fear of legal involvement. A lot of our patients have childcare issues and transportation issues that are preventing them from getting to their appointments at the schedule and time that we would like them to come. They also have employment issues or overall financial limitations. Some of them have jobs that are supportive of them taking time off to come to their appointments, and a lot of them don't. And just in general, they may be at risk for medical complications that are just getting in the way of them keeping their treatment the main focus. And so these concerns listed can really lead the patient to not adhere to their treatment recommendations, which then can lead us on the team to get frustrated with them. Next slide. So who is stigmatized in the addiction world? Laura already mentioned some of this. So individuals with substance use disorder, and especially people of color with substance use disorder, and especially pregnant people of color with substance use disorder. Also their friends and family members that are in their unit trying to support them get stigmatized. And specifically individuals who are receiving medication-assisted treatment. And it's not just the patients, it's us folks on the other side. So people who are working with this population and specifically providers who are offering medication-assisted treatment. Much of the coverage of the opioid epidemic has really focused on white rural populations, but the epidemic has affected Blacks and Latino people disproportionately as well. So we know stigma makes it more difficult to receive compassionate, high quality evidence-based care, and racism makes this much worse. So access to treatment dramatically favors white individuals who are 35 times more likely to receive a prescription for buprenorphine, which I think Dr. Reynolds will be talking about that later on. And so that's important to highlight here. And so who spreads the stigma? Unfortunately, it's also all of us. Patients themselves. I can't tell you how many times I've done an intake with a patient and we may be going through their drug use history and they're very quick to point out, well, you know, I've used cocaine, but I've never used crack. Now, technically that's the same substance, but they have their own sort of stigmatizing views about it. Folks in recovery can sometimes have stigmatizing views about what kind of treatment other people should or shouldn't be participating in. Us medical professionals, so doctors, nurses, therapists, we can inadvertently contribute to this based on the language that we're using, based on the resources that we are or are not working towards getting for our patients. Family members can participate in this, pharmacists, which has been a separate battle that we've been dealing with, and then folks in the criminal justice system and CPS workers. Next slide. So here's the vicious cycle of stigma that inevitably starts with labeling. So when a patient or client gets labeled as this quote, I don't even like to use the word, but quote unquote addict, when we use that kind of stigmatizing non-person language, that person walks away with a label that other people label themselves them with, or they label themselves with. That then creates the stereotype. So we're assigning a perceived image of a person with that label. So when somebody has that label attached to them, we start to fill in the blanks about what we think is or is not going on in their life. This creates this division, right? This us versus them. So that person isn't like me. That could not happen to me or somebody that I care about. And I think that goes back to that cause and controllability. So that if they're different than me, then they must be doing that to themselves. Then folks dealing with addiction end up losing social status because they are seen as less than, they are seen as less worthy or less deserving. And that leads to this overall discrimination. So we treat those people differently because of that initial label that somebody gave them. Next slide, which I think might be yours, Laura.
Yeah. So in terms of why all of this matters, interestingly, we have a lot of focus on opioid use disorder, but actually alcohol use disorder still remains, alcohol and tobacco remain the substances that kill the most people in our country. So we're up to over 100,000 overdose deaths from opioid use disorder, but 350,000 people die every year of alcohol use disorder. So not to forget about all of the substances. And as many of you guys may know, alcohol is actually the most toxic substance to the developing fetus when we think about working with pregnant women. So in general, 23 million people have a substance use disorder in the US, and there's lots of costs with regard to the criminal justice system, healthcare costs, and workforce loss as well. And not enough people are getting treatment. So again, that's what we're all working towards, that common goal of trying to get people access to treatment who need it. So stigma is really the main barrier to people receiving help. In our state, it also happens to be like if there is treatment easily accessible in their community, or if they have to travel a long way, transportation is a problem. So there's some other barriers too, but stigma is one of the main ones. So I'm going to go quickly through the research, but there's a tremendous amount of research on stigma as related to substance use disorder and where it sits. So this was a survey done with like the general public that found that generally people stigmatize people with substance use disorders much more than people with mental health disorders, including the most stigmatizing mental health disorders like schizophrenia. And also what it kind of contributes to is people dropping out of treatment. People who are in treatment feel stigmatized by their providers as well as by like family members who may know that they're going to treatment. So that's just some research about that. And including professionals. So when I saw this data, I was like shocked at how stigmatizing professionals are. So like somebody comes in for their primary care visit or goes to their dentist or, goes somewhere in the world to get healthcare, which we want patients, we want the people we work with to go and get their physical health needs taken care of. And they are stigmatized by the physicians they encounter, by the nurses they encounter, certainly pretty aware of like how criminal justice can be stigmatizing and the long history, which Katie went over around that. So we are part of the problem and thereby also part of the solution. And stigma related to opioid use disorder, which is not tremendously different than other substances, so there's different stigmas associated with different substances. Certainly illicit substances have more stigma than say alcohol, which is an illicit substance. But opioid use disorder and medications for opioid use disorder are highly stigmatized. And this is the information with regard to stigma related to medication-assisted treatment. So the good news is as more people get trained in medication-assisted treatment, the stigma appears to be decreasing. Now, one of the things that contributes to this stigma is the idea that not everybody takes their medication as prescribed, and that there's illicit use or diversion of medications, which Dr. Reynolds will talk about, and we should all feel free to talk about because that is a huge concern. Lots of medications are diverted, but this is a this is a narcotic medication, so that's different than diverting. The most diverted medication is actually in antibiotics. So I always like to remind people lots of medications are actually diverted, but this is diverted for in ways that can then make people's substance use disorder not get better if they're actually in treatment. So we always want to be vigilant about that and try and help patients understand how that's actually going to help keep them sick. So in general, these are some of the effects, a barrier to acknowledging the problem. So a lot of times why people remain in denial, like, I don't really have a problem. If you think I have a problem, then you have a problem. That kind of sometimes response we get when we try and approach someone. That's partly related to stigma because it's really hard to admit that you have a substance use disorder. And it certainly reinforces this idea that if this person really wanted to quit, they would, versus this is actually a brain disease. Individuals with substance use disorder are less likely to seek help because of stigma, and they're more likely to drop out of treatment if they feel like they're being stigmatized while they're in treatment or while they're seeking treatment. And then it's hard for folks to work in the field because our patients get stigmatized, and also we get stigmatized for working with individuals with substance use disorders. So this is a really old study, this little graph, which is actually that there's a misperception that individuals with substance use disorder have much higher rates than other chronic diseases, when in fact, it's really the same in terms of, you know, the most common chronic diseases being diabetes, hypertension, and asthma. So very similar relapse rates, and these are relapse rates for folks who are seeking treatment and are actively in treatment. They still have recurrence of symptoms while in treatment. And we don't say, oh, well, it means you're, you know, hopeless and we're not even going to try and help you anymore when people continue to struggle with symptoms of diabetes, for example. Whereas in the healthcare system, and I work with a lot of folks in the emergency department, they don't see anybody get better. They only ever see people at their worst. And so they often tend to have a pretty stigmatizing view of individuals with substance use disorders because they don't see any of the examples of people who get well. What helps is really changing our beliefs about cause and controllability, as Katie mentioned, and then education, personal awareness, treating people with compassion and respect, changing some of our language, and sharing stories of success. My hope for you guys is that you have stories of success and share those with one another, because sometimes it feels like the people who struggle more outweigh the people who really are successful, say with reunification and rebuilding their lives. So it's really important for us to share those stories of success with one another. And also that language matters. So these are just some specific examples of, instead of referring to a client as an addict, you know, refer to them as a person with substance use disorder. Many more words. So it takes practice. I always say it took me about a year to stop using the word clean and dirty. And when I go back and read my old progress notes, like I cringe at like some of the language that I use that at the time I didn't realize, you know, how stigmatizing it was. And now I have a different kind of awareness. So it just takes practice to change our language. And these are just some of the ways. And also clients use stigmatizing language about themselves. And so one of the questions is like, oh, well, should I use that language too? And in general, I don't. And I think there's an exception if you are a person in long-term recovery yourself. I think that answer may be slightly different, but I'm not a person in long-term recovery from substance use disorder. And so I tend not to use that stigmatizing language. And in general, you know, if somebody is calling themselves stupid, I'm not going to call them stupid also. I mean, I'm going to try and support them and build them up.
It can be a great opportunity, also education with your patients. So sometimes they want to use, there's a reason they're using sort of the old terms when talking about themselves in their recovery, and there's an emotional connection to why they're doing it. And sometimes it's that they're also still unconsciously connected to that shame. So that's why I tell my patients, like, I'm certainly not going to police what you say. You have earned the right to talk about yourself in your recovery and what language that you choose to do. Let me talk with you about why I do things differently and what that could potentially help in terms of the work that we're doing out in the community. But at the end of the day, yes, you have earned that right.
And so we're going to just finish up by talking a little bit about what we all can do related to influencing stigma. So whether or not it's clear to us and whether or not they're talking about it, the clients that we work with have tremendous shame and guilt. And they're in different stages of recognizing that, because when they do recognize it, it's pretty overwhelming, especially with respect to the impact of their substance use disorder on their children. That is hugely painful for people to admit. And so when someone's not looking at that, like, so I will often hear patients say like, oh, well, I never used around my kids, right? And therefore it didn't impact them. So I'll nod, because clearly they are not ready to go there we all know that substance use disorders, whether you use around your kids, impact them. Now, do they put them at imminent risk for harm? Not necessarily, but it impacts them. And so there's kind of a, a gradation about what that impact might look like. So helping to reduce that and not sort of forcing them to acknowledge it before they're ready. We know it's there, and creating kind of a place where they feel supported and validated will help them kind of go there and understand that aspect of their use. Adopting a non-judgmental stance is really important. Being compassionate, and one of the ways that people can understand, like, how do I be compassionate when this person has engaged in, behaviors that I find abhorrent, right? Like, they have put their children at risk. They have abused their children while under the influence, or neglected their children while under the influence. Like, how do I be compassionate towards that person? And so when you put it in the context of a chronic illness, it's a little bit easier. And so, like, it's almost like, how can you imagine being compassionate towards this person? The other thing is, if you've seen people get well, you do have an understanding of, like, the person in active addiction is almost like a different person than the person in recovery, or than the person who's not in active addiction. And people will describe themselves that way, and their families will certainly describe themselves that way. Like, so when someone goes into recovery and gets well, they'll say, oh, I have my old Katie back, right? Like, this is how you used to be versus the person that you became when you were in active use. And so trying to get back to the person, although we know actually in recovery, you become a new person, you don't go back to the old person, because you can never really go back. But for many people, recovery affords people, like, the opportunity to become, like, a better person than they ever would have been had they not had the experience of going through recovery. And that's where people can actually get gratitude for having had the experiences they have had through addiction. And then advocating for patients who are being discriminated against by institutional stigma or other kinds of stigma. So education for each other, by each other. Again, those sharing stories of success and using non-stigmatizing language. And the other main one is really being aware of our own biases. So many of us have family members who struggle with substance use disorders. Some have family members who are in long-term recovery, which is awesome, because we have that example of success. But many of us have people who are actively struggling, and that will influence our ability to be compassionate with the clients that we work with. And so just kind of keeping that in mind and making sure we're kind of getting support for that for ourselves. And that contributes to transference. So some of us grew up in families where there was active substance use, and that affected. So we are all drawn to this field for different reasons. And many, it's not uncommon that we've grown up in a family where there's been major mental health problems or substance use disorders, or we've experienced things that we want to help other people with. But we have to do the work ourselves as well in order to be as helpful as possible to others. And always, like, hope is a big thing to be able to hang on to in the midst of feeling like nobody ever gets better, people don't want help, and also being overwhelmed with the amount of sadness and destruction that sometimes we all are faced with in the work that we do. So the references at the end, but I will stop sharing my screen now. If I can figure out how to, I have like some weird screen happening. There we go. Okay.
Thanks, Laura.
All right, so that was a whole bunch of talking. Any thoughts from folks, or any experiences you guys have had related to stigma?
We call this the echo pause, by the way. We're very comfortable just letting people marinate on it a little bit. And then, so if you think we're frozen or anything like that, we're not. We're just, that's what we do. Yeah.
I just want to echo Laura that, when you talk about stigma and the language we use, I think that that's a really important piece. I think, like you said, it's even hard for us to accept some of those. And I've noticed too that it's especially hard sometimes for me to shift my language, especially when my patients are using the wrong language. And so that's really hard for me. But I've noticed that the more I try to do that, the more that it empowers them to use more encouraging language. So yeah, I think that's a barrier.
So I come to you all kind of from a different angle. As a forensic psychologist, I do a lot of evaluations for the court system of people who have committed a crime and have some sort of mental illness and disproportionately have substance use problems. But this whole talk today got me thinking about how stigmatizing the justice system continues to be. And even though forensics is kind of mental health side of the legal system, I still see that stigma as really apparent in that system, and that's unfortunate.
So I know we're running a little low on time. Katie, do you want to do your case?
Yep. Yeah. So we have a case presentation that's specifically about stigma. So I think it'll lend itself well to this conversation. So I know we are short in time, but people that know me will know that I can talk fast. So happy to share it. Okay. So Jay, is there any way to make that bigger? If not,
Yeah,
that's okay. I'll just sit
yep,
up close here while I read it.
on it.
Okay. Thank you so much.
Yeah.
You guys are giving me a eye exam. Okay. So our case we're going to talk about is Emily P. So Emily P is a 32-year-old white female. She's a single mother, currently raising 3 children, ages 2, 6, and 8. She works part-time at a coffee shop and is also enrolled in online college, and she utilizes West Virginia Medicaid for insurance. Emily was raised by her biological mother until age 14. Her biological mom was diagnosed with bipolar disorder and completed suicide when Emily was 14. Her biological father was never in the picture. Never knew him. She then lived briefly with extended family members, was essentially living out on her own at age 16. That was when the family members just kind of wanted to stop being responsible for her. She has a history of childhood neglect and also experienced sexual assault during adolescence. Her substance use began at age 13, initially started with alcohol and cannabis, and eventually progressed to opioids by age 16. She met her children's father when she was in active addiction. He was in active addiction as well. She had unplanned pregnancies at age 24 and 30. Her second pregnancy was somewhat planned, sort of not trying to not get pregnant, if that makes sense. She and her former partner now entered treatment at the same time when she was 24. She's remained consistent with her treatment and recovery. There were some slips and relapses here and there, but has always stayed present in her recovery, and he did not. She currently has approximately 4 years of continuous sobriety. There's a history of verbal and physical abuse from that former partner. Local police were called a few times by her and also her neighbors. She separated from him in summer of 2020, which, if you can imagine, was an incredibly difficult, stressful time to do that. That was the first summer of the pandemic. It was amazing that she was able to do that. She moved into her own apartment with the children. The children stay with her the majority of the time. They stay with their father on some weekends, and he has some extended family members help with him. She has this constant worry about whether he's intoxicated when they're with him, but she also worries about retaliation from him if she doesn't let him go. If she doesn't let the kids go to him, he often uses their time as some sort of chess move with her. She's currently in our advanced or monthly phase of COAT. So for us, that's patients that have at least a year of sobriety, and they've moved throughout our other phases of the program. She attends individual therapy on a biweekly basis, which is voluntary, and she's done so for years. She's diagnosed with opioid use disorder, which is currently in remission, cannabis use disorder, also in remission, tobacco use disorder, and post-traumatic stress disorder. In terms of agencies or resources that are involved or been in the past, and I listed this specifically so that you could kind of think about where some potential stigma that she's encountered with these various agencies. So she's been connected to our COAT program for years. She also received services with WV Medicine's OBGYN clinic through all 3 pregnancies, and then also has followed up care for the kiddos in the pediatrics clinic. Her youngest son is involved in the Birth to 3 program. As mentioned earlier, she She doesn't have any prior arrests, but she's been involved with local law enforcement when she has called them and or the neighbors have called regarding domestic disputes with her former partner. She is currently on HUD, so she utilizes that resource and is connected to DHHR. In the past, Emily really struggled with adhering to her treatment schedule and would miss therapy appointments or drug screens regularly. As you can see, she was navigating 3 kiddos, the fear of leaving them at home with a potential intoxicated parent, not having a car or actually a license at the time, although she does now. Since she has moved into her own place in 2020, she has been able to attend all of her appointments or reschedules them in advance. She attends all of her drug screens, hasn't missed any part of her treatment. So questions, I'll open it up to you all with our few remaining time, are the last 3 questions. So I'll ask you all, what are some areas in her life that you think she's encountered stigma, and what could that stigma have looked like, felt like? What recommendations would you have for her to increase the sort of continued likelihood of her having these successful outcomes? And then do you have any questions for us? We'll tackle just that first question. I think that's the most important question on there. So what are the areas that you think she's probably encountered stigma? Brandy mentioned the children's school. Yes, absolutely, Brandy. Great suggestion. So because she is one person navigating so much, those kids have missed school from time to time. I'm sure they've dealt with illness from time to time. She's had transportation issues. If a kid's late to school, she didn't have her own car to be able to take them to school. So that has been really difficult. Candy, absolutely. Thank you so much. She had a very distinct, so Candy mentioned the OBGYN clinic. She had a very different pregnancy. Her first 2, I'm sorry, her second 2 pregnancies were very different than her first pregnancy that she would talk about. She was utilizing medication assisted treatment through all 3 pregnancies, and the treatment that she got from the nurses on the labor and delivery unit were much different for her second pregnancies and third than her first one. There was a lot more stigma that she encountered. Mickey mentioned law enforcement. Absolutely. She talked about there was a lot of shame that she felt when law enforcement would come to the house, particularly when she had called them before, or the neighbors had called before, because the attitude from them was, well, this has happened to you before. Why haven't you left? And there were periods of time where she didn't have the option, the resources to be able to leave and to survive and to know the kids were going to be safe. Aurora said, being a mom in general, for anybody that knows her history or with a relationship ending, that's true. Even if we took all of the addiction and off the table here, my gosh, just moms in general these days are stigmatized. And I would especially say moms in the last 2 years that were during the pandemic, what you have been asked to do and to stay sane and healthy while doing it is phenomenal. That list is ridiculous. And such a great point what's been asked of her in that role.
I wondered about birth to 3. If there's, since birth to 3 comes into the house, is there ever a fear that they're going to call CPS for a number of reasons?
Yeah, great question, Colleen. She has had good experiences with the folks coming to her house, but a constant fear for her is her partner's involvement, and when partner is taking the kids to appointments, or when those workers are going over to the partner's house, the things that are out of her control. What does his house look like? What's the condition of his house? What kind of shape is he in, emotionally and physically when they're showing up? That is a constant fear for her. Great question.
It also reminds me just of the stigma of child protective services, right? That you are the people that take away babies, right? I mean,
Yeah.
no, this is, you guys are the folks who try and help families stay safe.
Yeah.
And so, that may be something that we can think about addressing and how to address that with the clients as well.
Yes, such a good point.
Speaking on behalf of my co-patients, stigma is everything from trying to apply for a job to if she had to fight to get her driver's license back, to going to the pharmacy, to everything.
Yeah.
And so.
Yeah, such a good point, Lori. And this is a person who experienced trauma at an early age. And so she has been dealing with traumatic events in her adulthood with not the strongest emotion regulation to start with. And she has been expected to do it all by other people who are watching her saying, you've got to get your stuff together for these kids. Oh, well, I appreciate the compassion and empathy you have shared with Emily. You've been able to highlight, yeah, what are some of the obstacles that she has faced. And I know if she were here, she would appreciate that compassion.
Thanks, Katie. Appreciate the presentation. Hopefully that kind of gives the group an idea of kind of what we're looking for as far as the case presentations. It can be around you know, a situation. It can be about a de-identified actual patient, you know, or client, whatever. It really is to just kind of get the discussion going. So don't feel like you have to have the novel of every question, you know, filled out or anything like that. Just give us what you have, and we can work with that. Don't feel pressure to fill everything out or have to have such a complex case or something like that. That's not the case.
And I altered some of the questions, so there's a sort of the
Yeah.
main case form, but I altered some of the questions that were really, I think, just going to help highlight this sort of case presentation. So please know you can do that as well as you're presenting it. If you're like, you know what, this is in the question I want to talk about, I really want to talk about this one, then please edit.
Yeah, it's not rigid at all. It's just meant to make the talking points come alive.
Yeah. Mickey made a really good point. She said,
Yep.
this is why I believe it is so important for CPS workers to understand addiction, because stigma can bleed over to CPS and we don't want that. Absolutely, Mickey.
We've
Look
got,
at that, 8:59.
I know. Well, 9 o'clock now. So we will we'll wrap it up. I'm going to drop the session evaluation link in the chat. Again, you'll get it again in the recap email, and you have a week to complete it, but that is your way of getting the CE credit. So please let me know if you have any issues accessing it or anything like that. And we will be meeting in a month on November 2nd. So be on the lookout for the reminder emails. We'll keep you guys posted. And in the meantime, don't hesitate to reach out to us if you have any questions or need anything. But it was great to meet everybody. We hope you found it beneficial, and will continue to hopefully make it beneficial moving forward.
Thanks everybody so
right.
much.
Take care.
Yeah.